have got an exciting program on, one of the favourite viruses for a number of people at NCIRS, and we've got two excellent people to talk about this, who probably need little introduction, but I'll do a brief one anyway. The first talk, which is an overview of the Australian situation currently with both Varicella and Zoster vaccine, is from Associate Professor Kristine Macartney, who is a specialist in clinical paediatric infectious diseases and has been closely involved with the whole Zoster story, in particular in her role as senior editor of the Australian Immunisation Handbook. And Kristine will lead off, and then we're very fortunate today to have Professor Tony Cunningham here. Tony has also been a stalwart of the whole Zoster story, amongst many other aspects of virology, and is currently the director of our esteemed neighbour and coffee provider next door, the Westmead Institute for Medical Research. So without further ado, I'll hand over to Kristine to open.
Well, thank you very much, Peter, and I too would like to acknowledge the Indigenous land on which we're standing and Indigenous people in the audience and our future leaders in particular in this room. So it's an honour to talk about this program today, and particularly I thought I'd put my first slide up referencing a paper that Tony, indeed, who I'm very much looking forward to hearing, published as a review of the management of herpes zoster in the MJA back in 2008. And this explains a little bit about what this virus is and does. It's an absolutely magnificent virus because it's labelled exactly around what it does. So it's the Varicella zoster virus. It causes varicella upon initial infection, so varicella being chickenpox, and then zoster or shingles or herpes zoster upon reactivation later in life. So these two diseases, they're in some ways quite distinctive because they happen at opposite ends of the age groups or the age spectrum, but of course they represent your same endogenous virus. So when you are infected with this virus, it ultimately, following a primary, secondary viremia and then a disease characterised by skin infection, ultimately resides in your dorsal root ganglia and lives there latent in all of us. So say hello to your own virus. I recently met mine when it re-emerged, and it's a really clever thing, but something probably you'd rather not have in you. So coming back to the idea of these two distinct diseases, you can see from the graph on the left-hand side here that really the peak of hospitalisations for chickenpox, as we know, are in young children, and hospitalisations for the elderly for zoster. Before the varicella program, basically this virus infected, about a birth cohort every single year, spread across the ages, particularly sort of early school age children. Only about 1% of cases had complications, but when you think that 240,000 people are being infected, that's actually a lot of complications. So secondary bacterial infection, pneumonia, encephalitis, cerebral ataxia, and various other conditions. And there were indeed about 7 deaths per year. So the varicella program with a single dose of vaccine at age 18 months was introduced in November 2005. And then in mid-2013, the single varicella vaccine was replaced with a 4-in-1 MMRV vaccine. Now, importantly, as I already alluded to, many of us in this room, in fact, greater than 97% of us, if you're all over 35, should be seropositive to this virus. So we don't lose antibody. What actually wanes, what the immune sort of dysregulation, I guess, is that occurs, or natural dysregulation is that occurs, is our declining T cell function, and that's what enables virus to reactivate. I'm sure Tony will mention more about that. But we're all essentially susceptible then to this entity of zoster. More than 150,000 new cases annually, most of these in people over the age of 50, and a cumulative lifetime risk of about 20%. But if you live to 85, you've got a 50-50 chance of getting zoster. And unfortunately, you've got quite a high risk of getting severe pain following zoster, which is called post-herpetic neuralgia. So the program for zoster started in 2016, and you'll see here just another publication which Tony was involved with, just an age-related incident rate for zoster in the two darker bars, two different ways of measuring it, and post-herpetic neuralgia in the white bars. So, coming back just a bit to varicella, and I'm only going to sort of take about 20 minutes of your time, so I'm quickly going to take you through this particular graph, looking for the pointer, which has wandered off. Oh, here we are. So if you see here, this is actually data published in 2013, analysing varicella hospitalisations up to mid-2010. And this is actually the hospitalisation rate, so very distinctive in children under 5 years of age. You can see here that when the vaccine was licensed, not much happened for a while. It was then recommended and hospitalisations fell somewhat. But you can see here from the coverage lines in both 24-month-olds and measured at 5 years that it wasn't until the vaccine was publicly funded and coverage skyrocketed up that actually significant declines in hospitalisation rates started to occur. But that was up to 2010. So more recently, with regard to coverage, we published this paper from a number of people at this centre just last week in JAMA Paediatrics, and it was actually an evaluation of the combination MMRV vaccine that I alluded to, introduced in mid-2013. So you can see here that what that actually did was two things. It also brought down the age at which we give measles, mumps, rubella, so the 4-in-1 vaccine now at 18 months of age. And this has led to a number of really quite pleasing observations that we've been able to demonstrate in the paper. Firstly, we've improved vaccine uptake by more than 4 percentage points, really up to 89, 90% now. We've improved on-time vaccination for the second dose of measles-containing vaccine. That's improved by more than 13.5 percentage points. So that's vaccination within a month of the scheduled age, now being 18 months rather than 4 years. So we're obviously also bringing forward the age at which protection occurs, and you can see that here on this nice graph which Brindley Holt generated. And we've also shown in a very sophisticated analysis by Heather Gidding and Han Wang that we're not seeing an increase in the risk of febrile seizures in relation to this change, because we do know the 4-in-1 vaccine is more likely to cause fever, but not when used as a second dose. So that's certainly been interesting from the point of view of a change to our single dose program, but still maintaining 1 dose. Now, what about disease out there in the community? Well, we really only have one jurisdiction, South Australia, that has high quality notification data for this disease. We have laboratory notification data from other jurisdictions such as Queensland, but we don't get any clinical details from that data at all. But in South Australia, where they have been tracking varicella in the community, so notifications even prior to the program, you can see here from this nice analysis from Maru, who's one of our MAE students, and looking at age-related notification rates, this significant decline in age-related notifications right here up to 2015. The same goes pretty much for the 5 to 9 years, and then even for the adolescents bumbling along around about at the same rate. So no big upswings here either. I mean, there is a little suggestion that the age of infection could be getting pushed back a little bit here, but really certainly no upswings in the age at which we're seeing varicella. And Maru's also extended the hospitalisation data analysis out to mid-2013, which is the latest data that we have from the AIHW. And again, here you can see these significant declines. So remembering that this blue line represents those aged less than 18 months who are not eligible for the vaccine. So we can still, that's where the greatest hospitalisation numbers are, or at least the highest hospitalisation rate. But again, very low hospitalisations in the older age groups. Just delving into this a little bit more in terms of the herd effect for these younger babies, so the ones who are not eligible for vaccination themselves. Maru's nicely demonstrated here that comparing before and after the program, we can see actually a 67% decline in hospitalisations in this age group, even though they're not actually vaccinated. And that compares with the 84% decline in children who are 18 months to 59 months who've really been eligible in this post-program introduction period to get a dose of vaccine. Similarly, the varicella program has been very successful at closing the gap in hospitalisations between non-Indigenous or Indigenous and non-Indigenous children. And we published data on this in the Bulletin WHO paper that Anita Hayward led, but Maru's updated this again to really show that now the incidence rate ratio in the 18 to 59 month group is really bang on 1. So that's the same rate of hospitalisations in Indigenous as compared with non-Indigenous Australian kids, closing the gap here. We still see a discrepancy for those in the younger age group and all ages. but that may well change as a larger number of people are vaccinated over the years. So what about actually formal vaccine effectiveness assessments? Well, there's been a paucity of these from Australia, unfortunately, and I'm not sure whether Sarah Sheridan is here today in the audience, but Sarah's now working for us part-time as a public health physician, and she did this analysis while up in Queensland with Stephen Lambert. And interesting, you can see here an analysis of vaccine effectiveness against emergency department presentation being, quite substantially lower, at least the point estimate, than the vaccine effectiveness against hospitalisation. So, this looks a little lowish, doesn't it, as compared with what you'd typically see for some of our other vaccines. But that 81% against hospitalisation is really quite compatible with what we're seeing in a meta-analysis and a number of other studies that have been done over many years, particularly from the US. Now, we've also done an analysis of VE against hospitalisation in our PEDS data. So this is our 5 hospital-based surveillance data from children's hospitals, and we see slightly lower VE again, and Helen Quinn's about to submit that analysis for publication. The other thing we've been doing with our Paediatric Active Enhanced Disease Surveillance Network is trying to better understand who these children are who continue to be hospitalised, either with varicella or with Zoster. And this surveillance was started back in 2007, so right around the time that the program was introduced. We don't have pre-program data, with this sort of level of detail, but we do know the majority of hospitalisations are obviously for varicella. Some of those children are immunocompetent, and some of them have received a dose of varicella before, but end up getting varicella. And actually about 3/4 of the hospitalisations are in healthy children. Many haven't been vaccinated, so that's the flip side of that. But, people think that if you're going to get hospitalised with varicella, you're most likely to have been immunocompromised, and that's not necessarily the case, even now, well into our 1-dose era. We've also been genotyping the strains, courtesy of Cheryl Toy and Dominic Dwyer next door at ICPMR, and we have seen a few Ochre strain cases here, but again, mainly in immunocompromised. So I'll quickly move on just in the next 5 minutes to what you don't want to get, which is what this virus does when it reactivates in all of us. And this is quite a shocking picture, but it really does represent a very certainly sight-threatening and serious complication of herpes zoster. One question that people have asked, and this is built on the back of a number of modelling studies and assumptions around why we reactivate the virus, is the incidence of herpes zoster rising even after you account for age and that age-related, age-relatedness of zoster? Is herpes zoster rising over time? Evidence from Australia, certainly evidence from the US, the UK and Canada all suggest that the incidence of zoster has been rising, but those rises predate the introduction of universal varicella vaccine programs, and indeed the UK haven't even introduced varicella vaccine, and they see a rise over time that's very steady. So we don't really know why this rise is, but that's a question you can ask Tony later at the end of the session. This particular paper has got a wealth of data in it. It's a paper by Ryan McIntyre published 2 years ago. And what I'm showing you here is actually just prescribing data for antiviral medications. It's one way of trying to sort of understand zoster that presents to the GP rather than hospitalisation data, bearing in mind that about 97% of cases of zoster just go to see the GP as opposed to being hospitalised. And you can see here that there's been this steady increase over time that predates the introduction of the program. So the other interesting piece of analysis around zoster that Maru has done as part of her work is trying to better understand zoster in Indigenous versus non-Indigenous Australians. And I've already alluded to the varicella data. So because we have quite a number of children who are Indigenous who are hospitalised with chickenpox, and we can use that data to delve into chickenpox quite well. It's a little bit trickier with zoster because of the fact that I already mentioned that a relatively small number of people are actually hospitalised with zoster, and you can obviously get zoster as a complication of a hospitalisation for something else. If you're ill, you might then evolve to have zoster. But nonetheless, we do know that, and I think I showed you or alluded to this already in the Stein paper, that when you look across the board, in most Australians, you can see this age-related, step up in incidence of hospitalisation for herpes zoster. But if you actually look at Indigenous Australians who are in the same age groups, you can see that it doesn't matter whether you're 60 to 69 years or 70 to 79 years, your rate of hospitalisation is actually about the same. So if you flip that around, you would say, you know, someone who is in their 60s is just as likely to be hospitalised with Zoster as they are in their 70s. So this is data that isn't for widespread release at the moment because we're waiting on a publication of this data in the MJA by Maru. So just a brief mention about the vaccine. It's very important to understand that this is actually the same vaccine virus that is contained in the chickenpox vaccine, but it is 14 times more virus packed into that tiny little vial. And it needs to be a lot greater in content to overcome existing antibody, get in, boost those T cells, and give that protection against Zoster. The vaccine, Zostavax, is licensed for use in people above the age of 50, and the NIP program, as I mentioned, started in November with a ongoing target cohort of those turning 70 years of age, but a catch-up for those 70 to 79 years, just a single dose at the present time. So what you're asking is, you showed us all of those Zoster cases and PHN cases in the older age groups. How was that 70 to 79 year age group picked? And without going into this in a lot of detail, it does represent a sort of a summary analysis of data from both the original shingles prevention study and then a study in 50 to 59-year-olds. Essentially, if you go by decade of age and you look at efficacy against either Zoster or against post-herpetic neuralgia, you can see that there's an age-related decline in vaccine efficacy, with efficacy being non-significant and definitely lower in the over 80 years, and not enough participants to assess post-herpetic neuralgia. In the under 59s, there's not enough cases of post-herpetic neuralgia to assess efficacy against post-herpetic neuralgia. So you can see here that even though efficacy drops off in the decade in the 60s compared with the 70s, it's sustained against PHN. And remember, there are many more cases of PHN in this age group. So this turned out to be what we'd call the sweet spot in terms of cost effectiveness for vaccinating this decade or cohort. But of course, it's a live attenuated vaccine. So you cannot control this vaccine well enough, safely enough, if you have a significant immunocompromising condition, either a medical condition or being treated with a medication that significantly impairs your immune system. So these people, unfortunately, are some of those who are highest risk of Zoster, but they're also the people who are contraindicated to receive this live vaccine. And there's been a lot of communication around this, our own fact sheets and frequently asked questions. We helped develop this table, which is actually now published in the Australian Immunisation Handbook as well. It's recently been modified to say that it's okay to give to someone on sulfasalazine alone. But it is very tricky sometimes to assess older people because of the complexity of both the medications they're on and the conditions that they may have. I'd just point out our safety surveillance for this vaccine using SMS back after vaccination in about 170 Sentinel clinics, predominantly GP clinics across Australia. And we know that oldies, I call them oldies, I shouldn't be too pejorative, but people of all ages will SMS us back, and really the event rate here on the SMS system is very low. The number of people needing to seek medical attendance in a short time frame after the vaccine is very low. So if you're healthy and not immunocompromised, this vaccine is very well tolerated. But of course, we were concerned about introducing this vaccine because of a case report from the UK back about 3 or 4 years ago that indicated that a man who was immunocompromised had been inadvertently given the vaccine in the UK. It hadn't been realised that the shingles that he developed was actually vaccine associated and that he was indeed immunocompromised. And very sadly, he went on to pass away from the vaccine strain virus, so from disseminated disease from the vaccine. Now, unfortunately, that sad situation has been replicated here in Australia. In March, the TGA issued a notification that an immunocompromised person who had been mistakenly given the vaccine also died from the vaccine. And this is something that we never ever want to see, should be avoidable, but was a mistake. So unfortunately, this vaccine does have risks. A case report of that particular incident is being written up and submitted for publication with the consent of the gentleman's wife. So we'll be learning more about that case soon. And I won't go through this for the sake of time, but there's been a tremendous number of additional communication activities, including just a handbook, immunisation handbook update released 2 weeks ago to deal with this. We don't think that inappropriate administration has absolutely stopped. We hope the message can get to every single provider out there, but I think it's very important to continue to reinforce this message. The last slide I would show you is just evidence of how much providers are taking this seriously. We operate a telephone service here, led by our New South Wales Immunisation Specialty Service. We've had a real increase in calls in the last few months since this alert has gone out, as you can see here, particularly from GPs and practice nurses. And here are the Zostavax related calls along the side here, gone up considerably in the recent few months. Predominantly GPs and nurses seeking advice where they may, just want some extra support or clarification around the guidance as to who this vaccine can be given to. So in summary, I'll just say that we're more than 10 years into our varicella program. We've seen significant declines in hospitalisations and notifications where we have them. Anecdotally, we still see outbreaks in schools, and one of our MAE students is working to investigate one of those up in Queensland. VE is not optimal. We're only using a single dose. We still continue to see some hospitalisations, and the question of whether we could ever routinely get a second dose onto the program remains live in my mind. Certainly there's a recommendation for this in the handbook. And Zoster, it's early days, 10 months into that program, no detailed coverage or impact data yet, and some concerns about inappropriate use. But with that, I'll finish up and hand over, most excitingly, to Tony, who's going to talk a bit more about both the Zoster vaccine that we currently have and one that's very, very far down the pipeline. Thank you.